I'm sure one of the burning questions that occurs to students when we talk about anti-nausea drugs are, what about the marijuana? Very effective against nausea. Well, we have that discussed too, cannabinoids. On page 244, we have table 13.1, and right smack in the middle, it discusses various cannabinoids. And probably the most commonly used synthetic THC, the main active ingredient in weed, is a drug called Marinol. It's dronabinol as the generic name, and then Marinol as the trade name. And this is used to reduce nausea and vomiting by attaching onto cannabinoid receptors in the chemoreceptor trigger zone and activating those, and then by preventing those 5-HT3 receptors from being activated also in the chemoreceptor trigger zone. So they can relieve severe nausea and vomiting. And of course, you know, we all know that for a long time, the only acceptable medical use for marijuana was for chemo patients. And they reported that they got really great relief from smoking weed. And but we're going to mainly discuss the synthetic form because, remember, officially marijuana is still a Schedule I drug. But we do know that these drugs can be either natural or synthetic. I've seen Marinol given also to dementia patients. Remember how dementia patients sometimes lose their appetites and actually forget about eating. And giving them Marinol helps stimulate their appetite, which makes sense, right? It gives them the munchies. So that can be effective for that too, not just nausea and vomiting. Now, of course, we know that the expected side effect can be a dose-related high, resulting in easy laughing, elation, and increased awareness. And we are all very aware that in whatever form it can do that. Adverse effects, acute confusion, allergic reactions, and even seizure-like activity. And unfortunately, along with the benefits that we are seeing with medical marijuana, we are also seeing an increase in ER admissions in states like Colorado that have allowed marijuana both for medical use and for recreational use. They are seeing THC-related emergency admissions for things like seizures and the drug not affecting them in a way they had anticipated. For drug interactions, we want to avoid any drug that increases sympathetic nervous system effects. So sympathomimetics, drugs for asthma that are going to stimulate epinephrine and norepinephrine. And once again, grapefruit juice that can interfere with metabolism in the liver. So for patient and family teaching, of course, nursing implications are discussed in the table on page 244, and patient and family teaching for cannabinoids are found on page 247. Typically, in the clinical setting, these drugs are going to be given when the patient hasn't responded to anything else. They are measured out according to body surface area. So they are going to look at height and weight when they determine the proper dosage for this. For liquid drugs, like any liquid drug, you want to encourage your patient to use the appropriate measuring tool. Don't just splash them into a teaspoon you get in your kitchen. You want a medicine spoon, one that's been properly calibrated. THC is a CNS depressant, so you want to avoid other CNS depressants. Watch for change in anybody's mental status. And then, like I said, can be given to older adults to increase their appetite as well as relieve their nausea. Next, we'll be looking at drugs that are considered pro-motility. These are given to kind of speed up the passage of nutrition through the GI tract, because when something's just sitting in your stomach and there's a situation where peristalsis is not working and motility is affected, that can really make you feel nasty and can lead to nausea and vomiting. So on page 244, we talk about pro-motility drugs, and then they're discussed in the text on page 248. Our prototype drug is a drug called metoclopramide or Reglan, very commonly given prior to surgeries. In fact, when I worked in labor and delivery and we had a C-section called, we knew automatically that one of the first things we had to do was go to the AccuDose, get out Pepcid and Reglan, and administer that for stomach acid and to keep the patient's motility going. In fact, it wasn't uncommon at all for a nurse who just sort of suspected that maybe the labor was stalled or there were complications and there would be a C-section later. It was very common to just pull the Pepcid and Reglan and a couple of syringes and just keep them sitting there just in case. You could always return them if regular vaginal delivery was accomplished. But we, often knew the signs and knew that surgery would be upcoming. So these particular drugs block dopamine 2 receptors in the chemoreceptor trigger zone. So they're good for postoperative nausea and vomiting, chemotherapy-induced nausea and vomiting, and then GERD, gastroesophageal reflux disease. It's expected that you will see drowsiness, fatigue, restlessness, maybe some blurred vision, other visual impairment, urinary incontinence, and insomnia. These drugs can make you both drowsy and unable to sleep. But severe adverse side effects can be depression and suicidal ideation. So that's something to remember. And of course, you're not going to see that after one dose like you'd give pre-surgery. But if you've got somebody who's in a situation where they're taking a lot of Reglan or similar drugs, they can have mood changes, and you need to at least warn them about that. And if this drug is considered to be needed, just tell them that if they have changes in mood, increased depression, they should let their doctor know. These drugs don't interact well with phenothiazines like Phenergan. Neither of the main types of antipsychotics, and then levodopa, carbidopa, because we are affecting dopamine in the brain. Antipsychotics and Sinemet, or L-dopa and carbidopa, they all affect dopamine too, so there's not going to be a real good interaction and can cause increased symptoms. When it comes to patient and family teaching, you want to read that on page 248. Monitor older adults for confusion or falls, of course, because this is working on their central nervous system. Monitor older adults, I said old adults, but older adults for Parkinson's-like symptoms or unusual facial movements. If you see that, remember we're blocking dopamine, and blocking dopamine can cause pseudo-Parkinsonism and tardive dyskinesia. So you want to hold that medication and call the healthcare provider. That's something the healthcare provider needs to know. Watch for orthostatic hypotension, like most drugs, especially with older adults. You want to give 30 minutes before meals and 30 minutes before bedtime, because these are times when you can have increased potential for nausea. If the person reports depression and other mood changes, tell them don't take the med, call the healthcare provider. One additional thing I encourage you all to read as you cover this section of Chapter 13 is the general nursing considerations for antiemetic drug therapy. On page 245, we've got box 13.1, and reading this just kind of reminds us of things that we should do as nurses when we have patients who have nausea and vomiting.